presentation.
Good
evening, respected teachers. Today we are presenting a case of a 65-year-old gentleman who is a resident of Trivandrum, Kerala. He is a shopkeeper by occupation. He presented to us with the chief complaints of exertional breathlessness for the last 4 months, palpitations for the last 4 months, and bilateral leg swelling for the last 2 months. The patient was apparently well 4 months back when he developed shortness of breath on exertion, which was insidious in onset and was gradually progressive. 4 months ago, he was able to walk for around 30 to 45 minutes and was able to climb around 2 flights of stairs. Then he noticed that he was having difficulty in these activities and his symptoms of shortness of breath progressed over the next 3 months. And on presentation, he was not able to climb even 1 flight of stairs or walk on level ground for around 10 to 15 minutes. On presentation, he had a history of sudden onset shortness of breath at night, which disrupted sleep, which is a history of paroxysmal nocturnal dyspnea. And there was no history of orthopnea on presentation. This history was also associated with palpitations for the last 4 months. The palpitations were intermittent. They were sudden in onset. Each episode used to last for around 5 to 10 minutes. They were predominantly at rest and also on exertion. And they used to resolve spontaneously with a sudden offset. For the last 2 months, the patient noticed to develop bilateral lower limb swelling. The swelling was initially noted around the ankles and it gradually progressed to involve the leg and mid-thigh. And for the last 1 month, he noticed that he's having abdominal swelling, which was also insidious in onset and gradually progressive. There was no history of facial swelling or reduced urine output or yellowish discoloration of the eyes or urine. The patient also complained of easy fatigability for the last 2 months. And he complained of lightheadedness on posture change while getting up from a supine position. The patient did not have any history of chest pain, pre-syncope or syncope or cyanosis. There was no history of prolonged fever and productive cough. There was no history of significant weight loss, no history of limb weakness and sensory loss. There was no history of joint pain or skin rash in the past. The patient had a history of heart attack 4 years ago in 2016. When he had an angioplasty done. He says that he has been taking regular medications since then, and he was asymptomatic for the next 4 years. He is a known diabetic and hypertensive. There is no history of similar disease in the past requiring hospitalization. There is no history of TB or TB contact, no history of blood transfusion. The patient says that he is continuously taking ecosprin, cholesterol-lowering drugs, antihypertensive and anti-diabetic medications. There is no history of heart disease in the family or sudden cardiac death. Patient is a non-smoker, non-alcoholic. There's no history of drug abuse. Appetite and sleep are reduced and the bladder bowel habits are normal. On presentation, the patient had significant symptoms, so he was admitted. He was given intravenous medications, and after receiving those intravenous drugs, his pedal and abdominal swelling reduced and his shortness of breath has also reduced and he is symptomatically better. So summarizing the history, we have a 65-year-old gentleman who is a diabetic and hypertensive for last 4 years, who suffered an acute myocardial infarction in 2016. He had an angioplasty done. He was subsequently asymptomatic over the next 4 years. When 4 months back, he developed dyspnea on exertion along with palpitations, initially in NYHA functional class 2, which progressed over the next 3 months to NYHA functional class 3. And for the last 2 months, he has bilateral pedal edema along with abdominal distension and easy fatigability.
So in 2016, he underwent a coronary procedure.
Yes, sir.
Then 4 years, he was completely asymptomatic.
Yes, sir.
And then he developed features of failures, dyspnea and pedal edema.
Yes, sir.
What do you think is the cause?
Dr. Tiwari, just 1 second. Jignesh, you are here. Jignesh. Dr. Anita Saxena is not here. She is unable to get in. Jignesh, you are here? Okay, Dr. Tiwari, continue, please. You please continue.
Okay.
Yes, sir.
So, what do you think is the cause after 4 years that he becomes dyspneic and palpitation?
Yes, so this our patient, he had a remote MI and he was intermittent in between period for 4 years. He was completely asymptomatic, and now his symptoms suggest that he is having congestive cardiac failure. So it could be a progression.
Sorry, I'm sorry. Probably I missed it. What the lesion? What for which artery and what was the lesion he was underwent?
Initially, he did not give the history, sir, and he didn't have any documents available with him. So we did not know which artery or which
Fine.
was present.
Okay.
So we came to know that later when we did the angiogram.
What was the LV function at that time in 2016?
It was mentioned as normal LV function, sir.
Okay. Go ahead.
Yes, sir. So the clinical problem which we have here is that we have a patient who had a remote MI in 2016 who has been asymptomatic for 4 years, and then now he has developed symptoms of CCF. So first differential which we want to keep is it could be a progression of his previous disease because he is a hypertensive and diabetic known CAD with an old MI. So it could be an ischemic cardiomyopathy along with pulmonary hypertension, which is causing congestive cardiac features, causing congestive cardiac failure right now. The second possibility could be that during the MI, he developed an ischemic mitral regurgitation, which was initially mild, and then later on it has increased in severity, which is causing congestive cardiac failure now. And the third possibility could be that he has developed a totally new onset disease right now, which we want to keep as a restrictive heart disease. It could either be an infiltrative cardiomyopathy or a constrictive pericarditis, considering his symptomatology.
If the patient was completely asymptomatic after PCI for so many years, he is
Yes.
symptomatic for this short period. So why do you bring the first one? The ischemic cardiomyopathy is the number one diagnosis.
So because he has a known history of MI, sir,
Yes.
and he is known to have a coronary artery disease. So could likely that he might be having LV dysfunction which has progressed over time, which he may not have noticed, or maybe he could have had a recent event 4 months back, which maybe he did not notice or he did not undergo evaluation for that.
He is diabetic.
He is a diabetic, sir.
And dyspnea could also be angina equivalent.
Yeah, maybe some progression of the coronary disease or other disease involvement of other disease of the same stent which are deployed. How many stents are deployed?
That we don't know, sir.
He told one stent, sir, when on asking him.
See,
Yeah, you do not know. He's telling one stent.
See, it is very unlikely that you have another etiology. You already have coronary artery disease and then
Yeah.
that restrictive physiology infiltrating.
As other diagnosis, better you should bring sclerotic aortic or a calcific aortic stenosis rather than bringing restrictive heart disease, infiltrative cardiomyopathy, constrictive pericarditis. What prompted you to bring this diagnosis?
Sir, valvular heart disease, that first question, sir, that calcific aortic valve we didn't bring because it doesn't have any history of chest pain or syncope, so which are the classical features of calcific aortic stenosis.
See,
And
if
this,
you see the natural history of aortic stenosis, most of the severe aortic stenosis patients are asymptomatic.
yes, sir.
So maybe he is having aortic stenosis for long, and then
Yes.
he becomes symptomatic and then have. What I am emphasizing again, one should know how many arteries and what was the anatomy of the coronary at the time of PCI was done, because you never know, he may have some silent event and which have closes the main artery and the codominant other artery may close and then he land up into a severe LV dysfunction.
Yes, sir. We couldn't get the records at that time, sir. So we don't know about the coronary anatomy at that time. Whatever data we have is what he told us.
You told the patient had a few episodes of PND.
Yes, sir.
So what can be the cause of PND?
So,
PND in common which condition?
It's a left ventricular dysfunction, sir. Left ventricular failure causing PND. We are thinking possibility of left ventricular failure.
Yeah. Any valvular disease?
sir, it could be mitral regurgitation because the patient also has symptoms of palpitations and dyspnea. A mitral valve disease, sir.
But mitral valve disease, mitral stenosis you get, but in aortic regurgitation you can get also PND like symptom.
Yes, sir. Yes.
Okay, should I continue?
Yeah, go ahead.
Just one second.
Sir.
Yeah.
Just 1 second. I mean, we are clearly with the history. We are clearly favoring. I mean, although we can discuss other possibilities, but we are clearly dealing with a ischemic heart disease with LV dysfunction maybe related to a cardiomyopathy that is developed over a period of time.
Yes.
What worries me and what is different, and that is, I mean, rather than the straight simple case, I mean, how many times have we seen a patient who is absolutely asymptomatic develop a disease, LV dysfunction, goes into dyspnea on exertion, and then go into even right heart failure, PND right heart failure over a course of 3 to 4 months? This progression of an absolutely asymptomatic individual from LV dysfunction to symptomatic LV dysfunctions to PND to PAH and then right ventricular failure in 4 months, does it not ring some alarm bells? What are the possibilities you are considering? What is happening? Possibilities.
So one possibility when we're considering a case of biventricular dysfunction, we can think of a new onset pathology that has caused both RV and LV dysfunction that can explain his symptoms.
So you mean to say that it's not sequential RV dysfunction? It is a new etiology for RV now.
Yes, sir, it is a possibility, sir, because we are having a biventricular dysfunction. Other possibility could be he could be having an occult valvular disease which was not present, which was not detected previously, which was mild, and it has recently worsened.
For example?
So it could be either a mitral stenosis or a mitral regurgitation, which has worsened of now.
Okay, you will consider mitral regurgitation worsening. Any other thing that has got some signs in your history also? What were these short-lasting palpitations you were talking about?
So they were sudden onset palpitations, which were predominantly at rest and also present at exertions, short-lasting episodes without any syncope or pre-syncope, and sudden offset. So another possibility could be, sir, he could be having intermittent episodes of tachycardias, which could lead to a tachycardiomyopathy.
Not exactly cardiomyopathy, but then, I mean,
tachycardia-induced worsening of
course,
ventricular function.
You have to discuss all the possibilities of very rapid worsening of heart failures in an otherwise asymptomatic individual. So all the possible etiologies on that front needs to be discussed in terms of worsening of the natural history of the disease, arrhythmias, infections. Everything has to be discussed, and you have already said in your history about palpitations. So palpitation with LV dysfunction, I mean, atrial or ventricular region will have very important significance as you move forward, right?
Yes.
Okay, you can go ahead.
Okay.
So these palpitations, that is short onset, rapid onset, and rapid offset immediately. Yes. So what do you think the cause of palpitation in your case?
So more likely from the type of history, it's more likely to be ventricular arrhythmias, sir. Because of the sudden onset and the sudden offset.
Regular palpitation.
Sir, we asked him regarding the character. He was not able to classify particularly whether it was regular or irregular.
Okay.
Continue.
We'll go ahead, sir.
Yeah.
Moving on to the general examination, the patient was alert, conscious, and cooperative, average built. There was no signs of macronutrient deficiency. The BMI was 22.3. The pulse was 60 per minute. It was regular in volume, regular in character, low volume. There was normal character. No radial or radiofemoral delay was noted. The vessel wall was normal, and all the peripheral pulses were equally palpable. The blood pressure noted in the right arm was 100/70 in the sitting position, which decreased to 80/66 in the standing position. So there was a postural drop in blood pressure noted. Both the lower limb blood pressures were similar, 116/70 in the supine position. The respiratory rate was 20 per minute, a thoraco-abdominal type, and the saturation was 95% at room air. The patient had bilateral pitting pedal edema. There was no pallor, icterus cyanosis, or clubbing noted. There was no palpable lymph nodes, no thyroid enlargement, no skeletal abnormalities. There was no peripheral signs of infective endocarditis, no signs of distal runoff, diastolic runoff, and the oral cavity was normal. Moving on to the cardiovascular examination, the jugular venous pressure was elevated. It was 15 centimeter from the medial end of the clavicle in the sitting position. There was prominent V wave and a rapid Y descent. The X descent was blunted and the A waves were normal. The Kussmaul signs was negative. Moving to precordial inspection and palpation. On inspection, the precordial shape was normal. There was no precordial bulge. There was no visible impulses. There was no scar, sinus, or fistula noted. On palpation, the apex beat was localized to the fifth intercostal space on the mid-clavicular line. The character was a sustained, non-forceful apex. It was an LV type of apex with a grade 2, no thrill noted at the apical region. There was a grade 2 parasternal heave along with an epigastric impulse, and there was no palpable sounds over the precordium or any thrill. On percussion, the right heart border was substernal. The left heart border corresponded to the LV apex. The left second intercostal space was resonant, and the liver dullness was noted in the right fifth intercostal space on the mid-clavicular line. On auscultation, the first heart sound was normal. The second heart sound, the aortic component was normal. The pulmonary component was loud. The S2 was narrow, split with varying during respiration. There was no S3 or S4. No additional sounds were heard. There were two distinct murmurs in the apical and the tricuspid area. In the apex, there was a grade 2/6 high-pitched pansystolic murmur, which was best heard in the left lateral position and in expiration, and it was radiating to the axilla. In the tricuspid area, there was a grade 3/6 high-pitched murmur, which is pansystolic in nature. It was heard best in the supine position. There was no radiation, and it was increasing on deep inspiration and on passive leg raising. Moving to the other system examination, in the respiratory system, the upper airway was normal. There was reduced breath sounds noted in the left infrascapular area, and bilateral fine basilar creps were present. In the gastrointestinal system, the abdomen was distended. There was no dilated veins on inspection. Shifting dullness was present, which indicates free fluid in the abdomen. There was hepatomegaly, 5 cm below the right costal margin, firm. The liver span was 17 centimeters, and systolic liver pulsations were present. There was no splenomegaly. In the central nervous system, no focal neurological deficits were present. So summarizing the findings, this is a 65-year-old gentleman who has dyspnea, palpitations with pedal edema for the last 4 months with a history of MI 4 years ago, and in between he was completely asymptomatic. From the examination, we are getting a regular low volume pulse with orthostatic hypotension. Elevated JVP is present with a prominent V wave and a rapid Y descent. There is no cardiomegaly. We have a parasternal heave and epigastric impulse with a loud P2. And from the murmurs, inference, we are getting a tricuspid regurgitation and a mitral regurgitation murmur. So with these findings and history, we'd like to make a provisional diagnosis of a severe tricuspid regurgitation with mild mitral regurgitation.
Hold on before you speak the provisional diagnosis.
Sure.
Come back. Yeah.
Sir.
So can you come back? Okay, summary of findings you have. Yeah, that's okay. Go for it. So, I mean, if you can discuss, do you think the patient is in failure or not? That's my first question at this moment.
He is in failure, sir.
Which side failure?
He is biventricular failure, sir, because he has evidence of basal crepitations, and along with that, he has an elevated JVP with pedal and abdominal swelling.
His pulse rate is 60.
Yeah, that's my pulse rate is 60.
How
Sir,
can you get pulse rate 60 with patient heart failure with bilateral crepitations, JVP raised, patient symptomatic with dyspnea?
so it could have been the beta blocker effect which he was taking previously.
Now he's also taking beta blocker.
No, on admission, we had stopped, sir.
So if stopped beta blocker, after how many days? This is the finding.
First day only we have examined.
First day, sir. We examined on the first day.
Would you like to comment upon the severity of mitral regurgitation?
Yes, sir. The mitral regurgitation, sir, we don't, in mitral, there is a pansystolic murmur at the apex which is radiating to the axilla. There is no associated flow mid-diastolic murmur at the apex. There is no associated S3. So it's likely that it is a mild mitral regurgitation, and there is no associated cardiomegaly also. That rules out a significant mitral regurgitation.
So again, don't you think it is a little unnatural that in a very classical ischemic left heart failure,
Yes,
where you reach the stage of PND, you don't have any LV dilatation, you don't have severe MR, you don't have any S3. It's a little uncommon to have.
Yes.
Little uncommon. And this pansystolic murmur at the right side, I presume you are saying tricuspid regurgitation?
Yes, sir. Yes, sir.
Hypertensive or normotensive?
Hypertensive TR, sir.
So in hypertensive pansystolic murmur, do you need to do the dynamic auscultation changes? Like, will it change on deep inspiration? A high pitch pansystolic murmur of a hypertensive tricuspid regurgitation, you said varied with respiration. Do you think it will vary with respiration?
So if it's a severe TR with significant RV volume, it may not vary with respiration, sir, because already the RV is volume overloaded. It may not be able to take in more volume during inspiration.
Hypertensive. It's a hypertensive. What is the? It's a hypertensive TR. So it's. I mean, it will not have too much of variation with
Yes.
either leg raising, and all these maneuvers of leg raising and all are done in faint murmurs where you need to clarify which murmur it is or distinguish two murmurs. As a matter of habit, we speak the tricuspid regurgitation in the same way, but hypertensive TRs would not. There's no need to comment upon these things. Okay.
Yes, yes.
Yeah, I mean, it seems like a little unnatural overall speaking that there is no LV dilatation and there's so much of symptomatology, and RV has also dilated. RV has also failed now.
Yes, sir.
Okay.
Are you overestimating the symptoms? Symptoms you cannot overestimate. Symptoms the patient is telling.
Yes.
And with this, what Dr. Rishi told, with this much of symptom and no cardiac enlargement, no third heart sound, how to explain?
Yes, sir. So
Yeah.
that is why, sir, in our etiological diagnosis, we had to think of other things also. So can I?
Yes, continue.
Yes, sir.
Yeah, please.
Yeah. So our provisional diagnosis after our history and clinical examination was a severe tricuspid regurgitation with a mild mitral regurgitation, severe pulmonary venous hypertension, moderate PAH with mild LV dysfunction, patient currently in congestive cardiac failure, sinus rhythm, NYHA functional class 3 at present, and who had an old myocardial infarction in 2016 is post angioplasty. So etiological diagnosis, we still put the ischemic cardiomyopathy as first, but it is less because he has history of old MI and he's presenting with cardiac failure now. But because of this presence or absence of cardiomegaly, significant symptoms, no S3. So we had to bring in and significant PAH. So we had to also think about other DD of restrictive heart disease as well, which could either be a restrictive cardiomyopathy or a constrictive pericarditis.
I think the first diagnosis that you are saying, ischemic cardiomyopathy,
Yes, ma'am.
that has to have predominantly left ventricular, the right heart failure, secondary to left heart failure.
Yes,
Whereas what you are showing is more of right heart and less of left heart.
yes, ma'am.
Even your pulmonary arterial hypertension is moderate, but you have severe tricuspid regurgitation, patient has fetal edema. So this is not really likely to be the picture that patient has all the features of right heart failure which are dominant compared to the left heart. How do you explain that by your first diagnosis?
We can explain it by possibility of RV myocardial infarction, ma'am.
But myocardial infarction happened 4 years ago. He was asymptomatic all along. Are you saying that he had another myocardial infarction?
One possibility is an instant restenosis if it was an RCA stent at that time, or if it was an RCA stent, it could have been an instant restenosis leading to RV dysfunction at present. That can be a possibility for why the right heart failure is more than the left heart failure, ma'am.
So when we say ischemic cardiomyopathy, we generally mean dilated and dysfunctional left ventricular dysfunction. It's not what you are talking about is a right ventricular cardiomyopathy or ischemia of only right ventricle. That will be most unusual. Similarly, having constrictive pericarditis with the history of PND, severe pulmonary venous hypertension, that's very difficult to explain. CCP patients are pretty stable clinically.
Yes,
They may have right-sided failure features, but they are comfortable. They're not so distressed like this patient you've shown us.
yes, ma'am.
There's no way you will be able to explain PND here because PND is not a symptom that is a soft symptom. I mean, it's a very hard symptom. When you are saying PND, you are committing to. There's absolutely no way you can run away from a left heart failure.
Yes, sir.
Means your assessment of PND may be wrong.
So one
Yes.
more possibility we can think of is a patient had an initial triple vessel disease which has progressed, and that patient had developed LV dysfunction and RV dysfunction, with the RCA being predominantly involved. leading to a further increase in right heart failure. And we can explain the PND also if he's having triple vessel disease.
Very unlikely to have RV dysfunction in this scenario. And LV is hardly any.
It is because of the biventricular involvement, sir. Both the ventricular involved, so we are having left-sided features also. He's having symptoms of paroxysmal nocturnal dyspnea and also the right-sided heart failure.
Is there any LVST?
I know, but the whole puzzle is not matching up, right?
Yes, sir. So because
Seeing all these findings, then you should not keep ischemic cardiomyopathy at number 1.
okay, sir.
Because ischemic, what do we mean by ischemic cardiomyopathy?
So ischemic cardiomyopathy is patient who is having a coronary artery disease with repetitive ischemia. There is associated LV dysfunction.
So there is no repetitive
So-
ischemia.
Yeah.
Yes, yeah.
And the LV dysfunction has to be the dominant. Here, your LV dysfunction says you are saying mild LV dysfunction.
Yes, ma'am.
So
Because
if
we
you
are
are
not.
saying-
Yes, ma'am.
So you should actually make severe LV dysfunction and then explain everything by LV dysfunction, severe PVH, PH, regurgit. It's like right heart secondary to left heart.
Yes.
Here, what you are saying is right heart is the dominant. Right heart failure is the dominant feature here. Then how do you explain class 3 dyspnea and PNDs?
Madam, according to them, there is no S3, no cardiomegaly.
Yeah, I know, but to fit in these findings is very, very difficult.
Can you show the echo?
Yes.
ECG, let's see the ECG first.
Yes, ma'am.
Yeah.
Moving on to the ECG, ma'am. The ECG with a normal standardization, it's a sinus rhythm with a heart rate of 75 beats per minute, axis of plus 45 degree. There are low voltage complexes noted in the limb leads, along with a poor R wave progression noted in the precordial leads from V1 to V4. There are no significant STT changes. There is a small Q wave noted in lead 3. And there are VPCs noted in the precordial leads on probably LV origin. This presence of this low voltage complexes may indicate that there could be a presence of an infiltrative cardiomyopathy.
Okay.
Moving on to the
So if
X-ray.
you are telling this with this background
Sir,
and you can sudden deterioration, can it be pulmonary embolism at that time? So 3 months back, when what you are telling, there is Q3 and there may be some possibly S here.
sir,
But he had no acute symptoms at that
pulmonary
time.
embolism will have a more acute presentation, sir.
Yeah.
Acute onset of severe dyspnea. His dyspnea was more of gradually progressive.
So no acute dyspnea.
Yes.
Okay. Next.
Yes. Going on to the chest X-ray. It's an expiratory rotated film. It's difficult to comment on the cardiomegaly. There is no right atrial enlargement. There is no pulmonary arterial enlargement. There is grade 2 pulmonary venous hypertension. And there is a left-sided pleural effusion.
And there is ascites also.
Ascites also. Yes, ma'am.
Marked ascites. Look at the abdomen, all white.
All right. Yes, ma'am.
It's actually pushing the heart up.
The heart up. Yes, ma'am. Can we go ahead, ma'am?
Yeah.
On the echo showed an LV dimension of 48 by 37 with an M-mode EF of 47%. The 2D AL method EF was 50%. If we look at the parasternal long axis view, we can see that it's a concentric hypertrophy. There is no septal wall motion. In the fourth chamber, if we see, then there is a granular appearance of the myocardium with a concentric thickening. The LA is not enlarged. There is mild, there is RV dysfunction along with a non-coapting tricuspid valve, and there is right atrial enlargement. If you look at the color Doppler here, then we see that there is severe tricuspid regurgitation with mild mitral regurgitation. The RVSP was 35 plus RA mean.
So there is no pH of very minimal pH.
Very minimal pH, mild pH, ma'am. This was the M mode of the mitral valve, showing a normal mitral valve motion and absence of any systolic anterior motion. The RA was enlarged with an RA area of 25.8. The left atrial volume index was normal at 23.5. The IVC dimensions were 23 by 18, and there was no it was non-collapsing with inspiration. If you look at the mitral inflow patterns, the mitral valve E by A ratio was 1.15. And if you look at the tissue Doppler, and the mitral E-wave deceleration time was 91 milliseconds. If you look at the tissue Doppler, the lateral annulus E prime was 6.02 and medial annulus was 4.4. So there was severely reduced relaxation. The E by E prime ratio was a 14, which indicates a significant diastolic dysfunction. If you look at the hepatic venous Doppler, in hepatic venous Doppler, we can see that there is a systolic flow reversal occurring in the hepatic veins, which indicates presence of a significant tricuspid regurgitation. The RV also showed dysfunction with a reduced TAPSE of 12.2 and an RV fractional area change of 30%. So overall, from the echo, we got the information that there is mild LV dysfunction along with significant RV dysfunction.
No, why are you saying mild LV dysfunction? It is LV systolic dysfunction. What about diastolic dysfunction?
There is
LV.
Significant diastolic dysfunction, ma'am.
Yes, so you should not say LV is showing mild dysfunction.
Yes,
You have to explain severe PBH, no?
Yes, ma'am.
So you have to say there is severe LV diastolic dysfunction.
Yes, ma'am. So LV systolic function is normal. There is severe LV diastolic dysfunction. There is RV systolic dysfunction along with significant diastolic dysfunction, and there is significant tricuspid regurgitation along with dilated right-sided chambers, RA and RV. Moving on to the cardiac catheterization data.
No, what is your echo? What is your echo interpretation? Why there is so much of LV hypertrophy or dysfunction, diastolic dysfunction? What is your provisional diagnosis before you go to angiography?
Provisional diagnosis is of an infiltrative cardiomyopathy, a restrictive cardiomyopathy.
Which one?
Would be amyloid because of the granular sparkly appearance.
Okay. And any other?
Infiltrative cardiomyopathy.
So that's the only diagnosis, amyloidosis. Did you talk about intra-atrial septum?
Yes, sir. Yes, sir. Intra-atrial septum
There's
is
no thickening.
there's no thickening.
Okay.
So I would like to take you back to your clinical examination and how small things that you say, maybe sometimes in order to drive your case towards somewhere and sometime in plain ignorance. Can you describe your apical impulse for me again, please?
Sir, it was apex was localized in the left fifth intercostal space.
That's apical beat, apical impulse.
Yes, sir. It was sustained in character along with, it was an LV type of apex without any associated thrill.
You said sustained and not forceful. When you are saying a sustained and a not forceful apex, you are committing yourselves to LV systolic dysfunction.
Yes, sir.
And do you think this kind of echo will ever produce a sustained and a non-forcible? Can you describe all the four types of apex for me? Non-sustained, non-forceful, forceful, sustained, not forceful, sustained. Examples. What are the examples of not forceful and sustained apex?
LV dysfunction, sir.
It's only one example here.
LV aneurysm.
LV aneurysm.
So LV. So do you think this echo will give you a sustained apical impulse?
So this should give a normal apical impulse.
And how do you define sustained, by the way? That's when we are going to basics then.
So the amplitude of the duration of the apical impulse, if it is persisting for more than 50% of the systolic period, that is defined as sustained.
Yeah, and in your clinical examination, you, of course, it's no hard fast that you will find all findings there, but not to find an S4 here again would be, you must go back and see your examination. Not to have an S4 here and to have a sustained apex here would not be something that would be easily acceptable.
Understood, sir.
Okay.
Okay, go for it.
The cardiac cath showed low SVC saturation of 33%, indicative of severely reduced cardiac output. The aortic saturation was 95%. On the pressures, there was a significant elevation of the dip diastolic as well as ventricular end diastolic pressures. The dip diastolic pressures was 18, along with elevation of the LVED of 32 and the RVED of 26. There was a difference of 6 mmHg between the LVED and RVED. The wedge pressures were elevated with a mean of 25, and the mean pulmonary pressures were 30, indicative of mild PH. The RA pressures were significantly elevated with a mean of 30 and a prominent V wave. The cardiac index was severely reduced, it was 1.2. So overall,
what was the aim to do the cath?
So cath we wanted to do to see the pressures, and we wanted to prove see whether the restrictive etiology, sir. Because from the echo we got a restrictive physiology, we want to rule out whether it's a restrictive cardiomyopathy or a constrictive pericarditis. So cath will help in that.
Did you biopsy? Did you do biopsy?
No, ma'am, we didn't do a biopsy.
I think if you're taking the trouble of doing cardiac catheterization, then you should do a biopsy on the right side.
Yes, ma'am.
We all thought that probably you did it to have a biopsy.
Sir?
No, biopsy.
I mean, so any MR you do?
Yes, sir.
MR is this. So just yes, ma'am.
Okay, go ahead. Yeah.
Yes, sir. So, ma'am, the tracings, the RA tracing showed a prominent CV wave with a rapid Y descent. This is the simultaneous tracing of the RV and LV, showing an elevated dip diastolic and diastolic pressures. This is third one is the simultaneous tracing of the RV and LV with changes during inspiration, changes with respiration. So the changes were concordant with a systolic area index of 0.9, which rules out constriction. And this was an overlap tracing between the LED and the pulmonary wedge, which shows that both were falling during inspiration, which also rules out a constriction. The angio, the left ventricular angio in the RAO view, it showed a thickened LV without any pericardial calcification. The end diastolic and end systolic volumes are mildly elevated with mild LV dysfunction. There is some hypokinesia of the anterobasal and the posterobasal and diaphragmatic regions, and there is mild mitral. The LV apex is not obliterated. If you look at the LV size,
End diastolic volume was 84 ml.
84 and ESV is 47 ml, sir. So angio-wise, EF was 45%. LV is mildly, end diastolic volumes are mildly elevated, sir.
I think MR is appearing little more than mild, and the LA also seems to be a little enlarged. So, anyway, okay. What does the RV angio show?
RV angio, ma'am, it shows a tripartite RV. The RV is dilated with RV systolic dysfunction. There is no obliteration of the apex. The RV OT is dilated, and there are no focal aneurysms noted.
Severe TR.
And severe tricuspid regurgitation is there.
Okay.
In the coronary angioma, in the left coronary angio, ariocaudal view, there was no flow limiting lesions noted either in the left LAD or in the LCX, and it was a left dominant system. On the right coronary angio, it was a non-dominant RCA. The RCA was stented at the time in 2016. Mid RCA was stented, which is now showing an ISR of around 60 to 70% severity.
Is there any other view for the left injections?
We have, it's not included in the presentation, sir, but other views also, it was normal, sir. There were no flow limiting lesions on the left system, sir.
Time is almost over, another 2 minutes.
Yes,
Non-dominant RC has been stented.
yes, sir.
I hope not. So move forward.
Do you think it was something? It was not an an MI at that time. It was the same disease.
At that time, he complained that he had severe chest pain, and he was taken to the hospital, and angioplasty was done like within 24 hours.
Because his left system's very clean and left dominant system.
Yes, ma'am.
So very, very unusual for a non-dominant RC to be stented.
Yes, ma'am.
Anyhow, you don't have any records, so we can't talk about it.
Yes, ma'am.
Okay.
Moving on, ma'am. Moving on to the MRI. MRI, the cine view shows the same thing. The RV volumes are dilated along with severe tricuspid regurgitation, dilated RA in the non-coapting tricuspid leaflet. And the 3-chamber also, there is no LV hypertrophy is there, and there is no evidence of systolic anterior motion. This is the 20-minute late gadolinium enhancement images. This is at the basal left ventricle. It shows a global subendocardial enhancement. And at the mid-ventricle also, there is a global subendocardial enhancement, which is not corresponding to any particular coronary territory. There is another mid-myocardial enhancement noted here in the inferoseptal segment. This could be related to that MP which he had at that time. In the 4-chamber view, we don't see any movement in the RV myocardium or in the interstitial system. In the T2 weighted image, there is no acute myocardial edema, and in T1, there is no infiltration, fatigue infiltration noted in the RV free wall. The LVEF by MRI was normal, and the RV volumes were elevated, and RVEF was reduced by MR. So because
What
of
is the normal RVEF by MR?
45% and above.
So it's very minimally reduced. It's 42.
Yes, ma'am.
Very minimally reduced. Whereas on angiography, it looked quite bad.
Quite bad, yes, ma'am. And because of this typical late gadolinium enhancement in the LV, this diffuse subendocardial enhancement, we put the possibility of amyloid cardiomyopathy. Because this is a diffuse subendocardial enhancement not corresponding to any particular coronary artery territory. So we investigated him for further amyloid. His albumin globulin ratio was normal. The 24-hour urinary protein showed a 686 mg. Benzone's protein is negative. His serum electrophoresis and his abdominal fat pad biopsy reports are awaited. So we made the final diagnosis of a restrictive heart disease, possibly infiltrative cardiomyopathy with severe tricuspid regurgitation, mild mitral regurgitation, mild pulmonary arterial hypertension, mild LV dysfunction with RV dysfunction, congestive cardiac failure in sinus rhythm, NYHA functional class 3, with the coronary artery disease who had an old inferior wall MI in 2016, and PCI to RCA was done, and now having an RCA stent ISR with nephropathy, hypertensive, and type 2 diabetes. And etiology is likely an amyloid cardiomyopathy.
So now we are talking of two diagnoses. One is MI and the other is amyloid.
Yes, ma'am.
How sure are we about CAD?
We are not very sure about that CAD because the previous we don't know his original coronary status, because anyways it was a left dominant system. So we don't expect the RCA to be a dominant supply. The only thing is that if there was a significant large RV branch which was supplying the RV, which might have been affected, which is causing RV dysfunction.
Your diagnosis doesn't talk about PVH.
Yes, ma'am. It's severe pulmonary venous hypertension.
So if there is severe pulmonary venous hypertension, you will have to say severe or significant LV diastolic dysfunction.
Yes, ma'am.
It's important to write that, because otherwise if you write mild LV dysfunction, then it will be taken as, not very significant. But obviously if there is severe PVH, obviously his LV is very, very stiff.
Yes, ma'am.
Okay. Are we done, Dr.
Yes.
Shantanu? All right.
Already the time is over.
I was waiting to hear from you. Thank you.
I already told once. Thank you very much.
Thank you.
Thank you, you guys from SreeChitra. Thank you very much for this wonderful case. You have presented a very good case.
Yes.
And I thank all the examiners, all the students, and those who participated. As a thanks and gratitude from UCD on our behalf.